Hello there. My name is Scott Elsey. Um, Today I'm going to be talking about treatment options for opioid use disorder, specifically kind of the moderate and severe levels of that. So what is severe opioid use disorder? The first thing we need to know is that opiates are drugs that are derived from opium. So that's going to be heroin, opium, morphine. They come from the plant, essentially. Now, opioids, which sounds very similar, are synthetic drugs that are kind of created to mimic or imitate opium, or the effects of opium. So that's going to be your prescription drugs like oxycodone, hydrocodone, methadone, fentanyl, all sorts of those. Nowadays, the term opioids kind of also covers just the whole family of opiates, so it's a broader term for all of those. Now, moderate or severe opioid use disorder is essentially the same thing for the old term in the DSM-4 of dependence. So that's kind of what you typically view as addiction. The mild rating would be what abuse was in DSM-4, and that is kind of more requiring education, and you made a bad mistake and now you're trying to change. So, but with moderate or severe, we're talking addiction. And that means that that person has met at least 4 criteria out of these 11, or for severe, it's got to be at least 6 of these criteria. These criteria from the DSM-5 include things like, does the person have a tolerance? Do they have withdrawal if they don't have the substance? Are they having cravings for the substance, in this case opiates? What has it had a negative impact on mental or physical health? Are they doing regularly doing dangerous, putting themselves in physical harm by using this? Are they using more than they were intending to? Are they trying to quit but struggling to do so? So those are like examples of some of those criteria. The person has to meet at least 6 criteria to be listed as severe. Some of the most commonly abused opiates, heroin, obviously, but morphine, codeine, fentanyl, meperidine, oxycodone, hydrocodone, hydromorphone, and oxymorphone. So that's going to be your Vicodin, your Percocet, your Oxycontin, fentanyl. Those are the typical ones. It's really the opiate use in this country has really become somewhat of an epidemic. So here are some of the statistics around that. The deaths due to drug overdose is just continuing to skyrocket in the U.S. The majority of deaths due to drug overdoses, it involves an opiate or an opioid. So over 6 out of 10 drug overdoses is due to opiates. So not meth, not cocaine, not, it's opiates. And that number's staggering. So since 1999, the number of overdose deaths has quadrupled. So that's a 300% increase. Interestingly, since 1999, the amount of prescription opioids sold in the U.S. has also nearly quadrupled. So while we spend a lot of time talking about heroin, there's the prescription opiates are a big part of this. Now, between 2000 and 2015, more than 500,000 people have died from drug overdoses. 91 Americans die every day from an opioid overdose. So what are our options as far as how do we treat this? Well, the common one right now is drug and alcohol treatment itself. It's using the disease theory or disease model of addiction. Now, opiate replacement is another option. And that's usually using another opiate or an opioid antagonist to combat the effects of the opioid. So that's, you hear about methadone, which is an opiate, buprenorphine, naltrexone. These are options to keep the addiction at bay. Now, the third kind of option is just really a combination of the first two. It's using these pharmacological options as well as using treatment. So it's saying, I don't think just the medicine on its own is enough, but I also don't think the treatment on its own is enough. So it's kind of taking both of those ideas and combining them, fitting them together to be hopefully a better option. So with behavioral treatment, that's where we're talking what you think of it like a recovery treatment center or something. Usually that's involving the disease model of addiction. The disease model of addiction describes an addiction as a disease with biological, neurological, genetic, and environmental sources of origin. The traditional medical model of disease just requires that there's an abnormal condition that's present that causes discomfort, dysfunction, or distress to the individual who's afflicted by it. Well, that fits with addiction, and we know that the brain is impacted and brain chemistry has changed. So that's where we get that disease idea, is that there's an organ in the body that is impacted. Now, there is a controversy around this. Is addiction a treatable disease, or is it just a serious behavioral problem? Well, it's probably both. So you can argue about which one it is, but in reality, it seems like it's kind of a mixture of the two. And yeah, there's not a lot to be gained from arguing about it. It's better just to focus on solutions. Now, either way, whatever you view it as, the focus really is on changing old ways of thinking, old ways of behaving, and replacing them with new, healthier thoughts, mindsets, viewpoints, and behaviors. Some of the common kind of effective modalities and resources that you're going to see within treatment for drug and alcohol addiction, or in this case, opiate use disorder, that's going to include individual counseling sessions. Group therapy is a really big one. We often see co-occurring issues, so there's going to be mental health issues alongside the addiction, and urinalysis testing or other drug testing methods. So the treatment levels that can come in the form of going away to inpatient for anywhere from a month to 6 months or a year, depending on level of use. Intensive outpatient is kind of it's group typically, and it's 3 times a week. Outpatient is once a week or less. So they kind of a step down process as far as treatment there. As far as common theories or therapies used in treatment, motivational interviewing is a big one that's becoming much more and more popular as far as working with this population. CBT, cognitive behavioral therapy, is also widely used. Again, we're looking at dealing with behavior. Even when we call it a disease theory of addiction, we're talking dealing with behavior. So because of that, we also have dialectical behavioral therapy that can be used. Some really depends on the clients. Now, with the pharmacological treatment, this is becoming bigger and bigger. Now, the first one that we're going to talk about is methadone. That's been around the longest. It's been around since the 1960s. And so because of that, it's also had the most studies done around it. It's a slow-acting opioid agonist, meaning it kind of it's an opiate, but it's taken orally, so it reaches the brain slower, so it's not being shot up with a needle, it's not being smoked or snorted or anything like that. So it reaches the brain slower, and it cuts back on that high feeling, and while preventing the withdrawal symptoms that are part of the opiate experience. Now, it it prevents the withdrawal symptoms in the same way that heroin would. You're putting another opiate in your system, so you're not withdrawing from it. So that's part of that. Now, methadone can work well for patients who don't respond well to other medications. It's also kind of only available through these approved outpatient treatment programs where it's dispensed daily. So it's kind of dosed out to people. So that can be a bit of a hassle, but it's better. It's usually considered better than using heroin on the streets. Now, buprenorphine. This is a newer medicine or drug. It's newer, so it was approved. The FDA approved it in 2002. So it's newer on the scene. It's not been used since the 60s like methadone. And it's a partial opioid agonist. So it's partially an opiate. Now, the one we really want to talk here about is Suboxone, the brand. And the reason for that is that it is buprenorphine that is mixed with naloxone. So now buprenorphine on its own relieves drug cravings without producing the high or dangerous side effects of other opiates. Now, it can be abused though, and that's where the naloxone comes in. Naloxone is an opioid antagonist, so it counteracts the opiates. You take it orally or under the tongue, sublingually, to prevent these attempts to get high by injecting it. If you were to inject it, it would throw you into immediate withdrawals, which would be highly unpleasant. So, it has also been approved to be administered and prescribed by doctors. So you don't have to go to these special clinics. A doctor can just, your primary care physician could just prescribe it. So that expands its availability to people. It's also, they've approved a couple generic forms just recently of 2013, so it's becoming more and more affordable. Now, naltrexone is another opioid antagonist. It blocks the analgesic action of opioids. It's non-addictive, and it doesn't lead to the physical dependence on the substance. Downside of it, it's dosed daily, so that's a struggle for people. So it's also kind of limited its effectiveness. Vivitrol is an injectable, long-acting form of naltrexone that just recently got approval for treatment of opioid addiction. The benefit of using Vivitrol is that it's administered once a month, so you don't have that daily dosing. Some negatives of that is there's been a lot of reports that people start, it doesn't maybe quite last that full month. So there's kind of some risks there, but some final thoughts around this. I mentioned this earlier, the controversy around whether it's a disease or a behavior really seems to be less problematic in practice than in the simple terminology. People get really tripped up on this, like, well, is it a disease or is it, are we victimizing, or letting them blame other people? Well, okay, not really in this case. In treatment, even with the disease theory of addiction, the focus is on taking responsibility for your own actions. But while still recognizing that brain chemistry has changed, and therefore there's things we need to look at with that. So the opioid epidemic has to be combated on multiple fronts. Doing just one of these isn't enough. It is not enough. There's a reason that the relapse rates are as high as they are. They are astoundingly high. And especially the longer the time goes, the higher chance of that person eventually relapsing. So the statistics are depressing when you look at them. And so you have to view it on all these different fronts, using a whole holistic view of humans, doing behaviorally focused treatment, using pharmacology if need be, and spirituality. It's got to be involved. And I think part of that we can attribute to AA and NA. They have really, Alcoholics Anonymous, Narcotics Anonymous, that's 12-step programs. They have really encouraged and popularized the use and importance of spirituality and faith in the recovery process. They've gotten less specific to the Christian faith over the years. It's become more broad and less focused on that, but there is still some value in that, and I think that's important to recognize as far as the treatment goes. So, and often being involved in AA or NA groups is often required as part of that treatment process and highly encouraged. So here are my references, and thank you for taking the time to watch this.